All right, so I'll talk about the benefit zone of endoscopic spine surgery. We've been doing endoscopic spine surgery now for almost 7 years at the university, and it has been a really interesting road how to practice this type of surgery, how to train people, and it has been incredible. Just my fellow from last year sent me a text message a couple of weeks ago, and he had done an endoscopic surgery on a senior partner, and that told me that we're doing something right. Here's my disclosures. I do teaching for J&J, Globus, and Joymax, none of which should be highly relevant for this talk, however. So here are the learning objectives for this talk, and again, everybody's sure tired. You guys had some food, so interrupt anytime. This should be very open. And so I want to understand and convey the concept of, when we do surgery, really the outcome is highly dependent on how complex the procedure is. I would like to convey different indications for this type of procedure. We hear a lot about endoscopic discectomies, but believe it or not, this whole talk has only one slide with the word disc in it. Amazing? Okay, all right. Okay, I'll keep going here. Explore, and then, I want to show you also that even in the role of being a totally normal spine surgeon, this technology is really helpful in helping any kind of patients. Again, I have a university practice. Nobody comes to me because I'm doing endoscopic spine surgery. Nobody knows that. So I just have it in my practice. Here's the outlay, and the outlay is highly sort of like, it was really interesting is Dr. Michael Meyer is a very prominent spine surgeon in Munich, and I was in Brussels last year, and that was the very first time a very conservative surgeon like him was like, okay, well, this field is real. And so he gave this long talk about the parallel universe. So I'm going to have fun parallel universe pictures in the whole talk to keep you guys awake. Believe it or not, even if you're not interested in MIS or if you're not interested in endoscopic spine surgery, the foundation why we do all of this comes from the classical open surgeons. And in this case here from Dr. Chapman, who is really an amazing surgeon. I send him a lot of patients. I see his patients. We go back and forward. I have nothing but greatest respect for him. And he published this great paper with more than 1,500 patients, and he looked at why do patients have complications. And they looked at all these tiny little factors down there, all written in small letters. Don't even try to read through it, but they looked at a lot of factors why we have complications. And one of them was the invasiveness index. So how much surgery do we do? How much cutting do we do? How complex of a approach do we choose? And interestingly, when they looked at all different organ systems, so they had 6 different organ systems, as you can see here outlined here. So 6 different organ systems, they look at complications. And the 2 factors that were always associated and highly significantly associated were age and invasiveness. So our colleagues who do not like the idea of having an endoscope or a little tube or anything else that is small for that sort of sense, really gave us the motivation and the reasoning why, as a patient advocate, as a patient friend, and as a doctor, you should be at least somewhat interested in that. Now, you don't need an endoscope or a tube or a microscope to be a minimal invasive surgeon. That's why I'm putting this up there. The AO spine, we have this MIS task force under the leadership of Roger Hartle. We already heard his name before. And we kind of try to think about it. So endoscopic, as a minimal invasive spine surgery is a moving field. What was minimally invasive 20 years ago is standard of care today. We are just pushing, we're trying to push the envelope in order to reduce the systemic surgical stress and the local tissue trauma. That's it. And there's different ways to do that. Using aqua mantis for deformity surgery is minimal invasive surgery because you decrease the blood loss, which is it's an organ system blood, right? So there's a lot of definitions for that. It's a moving field. Here we go. So let's start talking about complexity. And we're coming up to the only slide with discs on it. So let's talk about low complexity surgeries. It's kind of like going to the car dealer and you're like, okay, you know what? I have $10,000. I want to buy a car. So if you go to the Toyota dealer on the left side, you get a Corolla. If you go to the Mercedes-Benz dealer, you get an A-Class, which looks like a moving, box, right? And it tilts over, by the way, too. So that's kind of what you get economy. So, you could argue that it really is not a big difference, right? Why should I go to the expensive brand, if the Corolla can do everything, right? And it's a little bit like that too with minimal invasive surgery, very low complexity surgeries. And that's the only slide on discs, right? So we have very good data. If you look at this graph in the left lower hand, which is going to follow through a little bit here, if you look at the complexity on the x-axis, so we have a discectomy, laminectomy, cervical thoracic, arthrodesis surgery, then, adding, having like minimal invasive surgery, in this case, like full endoscopic spine surgery, decreases the invasiveness. You can accomplish the same goal of the surgery with cutting less tissue, right? So you can bend the curve, if you want to say so. Having a discectomy is a very simple procedure. I can probably take out a disc with a, toothpick or a, fork. Right, disc, I mean, like, how hard can it be, right? It's not a very difficult procedure. And so for that reason, the difference of using a very fancy technique and a more traditional surgery is small. It's 3% in the literature. Kind of like all of those are the best studies we have, all prospective randomized controlled data, the best evidence we have. So 3%, so you operate 300 patients. If you're an endoscopic surgeon, you have 3 patients fewer with some type of complication. So not a big difference. But let's go to the moderate complexity procedures. So we're back at the car dealership, but this time you are actually fancy and you're a neurosurgeon or a spine surgeon, making a lot of money. So you're like, I'm not, no, right? But you happen to be at the same dealership, right? And yeah, that's what happens at the dealership. And what about the high-end stuff? So then we're talking about, what can you get at a Toyota dealership versus a Mercedes-Benz dealership, right? But you get the idea, right? So the range of what you can do with these technologies is very different. So let's look at something that is a little bit more moderate, with more complexity. Start with a case here. So a 57-year-old male, he came to me. Obviously, nobody else in the state of Washington wanted to touch this guy. He had a BMI of 60. Thank you so much, whoever sent him to me. And he was really getting weak. Also started to have bladder function issues. Started to retain, and you see his spine here is trapped in this gigantic body of BMI 60. But he had clearly needed help. And that's where a procedure like endoscopic spine surgery comes in handy. As you can see, here's up there on the left upper hand, you see the tube, 14 centimeters. It's more than 3 inches at the hub. So you could imagine to do this surgery with an open system or an MI system would be impossible, right? Anybody uses metrics. I mean, what's your max reach? How far does anybody go? Does anybody go beyond 9 centimeters with metrics? Anybody? 9 centimeter metrics tube is pretty much what more than that is hard to work in there because, the bayoneted instruments still go in there, the drill gets stuck, but this is 14 centimeters. So, and so we did a 4-level laminectomy in him and it did very well. He's 12 months out on the left lower extremity, on the right-hand side down there. He's with my EMP, allowed me to show his face. And he had a fantastic outcome. His bladder function get better. As you can see, the pain scores improved, and he has done really well. He's back at his job and works. And so here's one of these post-operative images. And you can see what you can accomplish with this type of technology is that you can spare the facet joints, which are there, and still obtain a very nice decompression of the thecal sac. With the AO spine, the same group that you've seen before, we've written a paper with 30, Eric, you're on this too, right? You're on the paper, right? Yeah, Eric is on it too. And with the best experts that we know, we made this new nomenclature system because one of the issues right now is that when you do a med surge for these procedures, you don't find them, right? Some people call it like percutaneous schmuck, other ones call it like blah, other ones call it pelt, telt, schmelt, you name it, right? You can't find them. So this was an attempt to put in 30 of the leading surgeons together and with the help of the AO, find a system that is logical. So it's approach corridor, surgical technique, segment of the spine, and is modular, and you can build on that. And so that's what we did there. So and here's the procedure. So laminectomy, bilateral medial facetectomy, we call lumbar endoscopic ULBD, that's the name for unilateral laminotomy for bilateral decompression. Here's a couple of figures from one of the books that we put together. This is some intraoperative pictures. I don't want to bore you with that because I want to really give you more of the data that we have right now. What Eric talked about before, the target, right? There's nothing more important than the target in these procedures. You have to get your target, right? It's not like open surgery where you have like the spinal process, the facet joints, a little bit of TP. You can put your big finger in there and feel around. You don't have the luxury, right? So you need a target area that you can identify. For example, for this procedure, it's the inframedial edge of the lamina. And you need a principal anatomical landmark that guides you through the procedure. So there's no, and that's also, I think, why, we're working with robotic systems to kind of get it there because it's so highly precise and so highly targeted. So now what's the evidence that this is any better for laminectomy? So let's look at the best trials of open laminectomies. So here's a recent study here, and this was a SLIP trial, and they looked at prospectively at patients with spinal stenosis, and 124 patients underwent decompression alone. Here are the complication, dural tears, in fact, nothing special, but in this best data that we have, it's 29% complications, and again, they're listed here, so adverse events, reops, 13 of 124 patients. Another study here is laminectomy plus fusion versus laminectomy. Actually, sorry, this was a SLIP study. 35 patients, similar complication rates, so between 30 and 40%. We looked at endoscopic lamis at our place. We enrolled 95 patients. Here's the different levels. Learning curve, right? So the operative times were much longer in the endoscopic ones versus the microscopic ones. However, the hospital stay was much shorter with the endoscopic ones. So it's better for the patient, more work for the surgeon. And to our surprise, actually, the back pain and the leg pain outcomes at a 1-year follow-up was actually better with the endoscopic ones versus the MIS. And again, we can talk about that. And interesting, that was the beginning of our learning curve. So I mean, those were the first 50 endoscopic lamis we did, and they did better than the MIS lamis that we've done thousands of. So that was kind of surprising. But again, for this talk, the interesting thing is also the complication rates were lower. So from MIS lamis, 26% to 8%. And again, the adverse events, mainly in the microscopic ones, were urinary retention, which was transient, but still, a couple patients needed a Foley catheter afterwards. And we didn't see that in this cohort, but it can obviously happen too in these patients. More papers in the meantime that have been published. For sure, the most prominent surgeon in the field is Dr. Rutten. He looked prospectively at 72 patients with the same type of procedure. They had in their series roughly 14% adverse outcomes. Another recent paper where they looked at that, they actually compared minimal invasive biportal and uniportal surgeries, and they didn't see any significant differences, but it was very much in line, the complication rate with the other papers, so 11% there. Another recent paper in the Journal of World Neurosurgery, 106 patients that underwent ULBD for spinal stenosis. Again, as all the other papers, found significant improvement of back pain, leg pain, and here the adverse events, incomplete decompression, dural lacerations, delayed wound healings, 4% complications. So if you put all this together, so this is all the data that is currently available on this, the numbers look now very different, right? It's a moderate complexity surgery, and suddenly we look at traditional surgery, which is 34%. And again, you really have to look at your data, and I think that's pretty accurate. I mean, again, this is the best data we have for laminectomies versus endoscopic, roughly 9%. And I would sort of say that this difference you can't ignore anymore. So I think in moderate complexity type of surgery, now we're talking more than 20% difference. So 20 out of 100 patients are going to have issues. Even if the complication is only a, transient urinary retention, believe me, if you would be the patient and somebody shoves up a catheter, yes, you would call. It's not a great outcome, right? So we have to take that very seriously. All right, so I want to sort of conclude the talk here with just a couple ideas of high complexity stuff, right? Stuff that we don't have any data yet. And again, some of this stuff is going to be combined with other technologies such as robotics type surgery, which we're working on too. But for this, with cervical, thoracic, arthrodesis, just a couple cases. So again, same nomenclature. Let's look at transforaminal endoscopic discectomies. Here's a couple of intraoperative pictures. Again, target area is the caudal index level SAP. Principal anatomical landmark for this procedure is the pedicle, the caudal index level pedicle. Here's a patient, 68-year-old female. She's 1 year after they had other surgeons had attempted to take out this disc herniation there. You can see that there. She had an arthrodesis surgery. They got a massive CSF leak, bailed out. She came to me 1 year afterwards with the pain diagram, as you can see down there. She was greatly myelopathic. What do you do with her? So you know that she had a massive CSF leak. So if you go in back there traditionally, everything you're going to see is CSF. Or you can go retropleural, which is going to be very interesting too, because you're going to have a retropleural as a cavity that is going to be filled up with CSF. So both of the alternative strategies could have been potentially a major disaster. And so that's where technology like that really comes in handy. So we did a transforaminal discectomy. Intraoperative, we saw the dural tear. You can see it down there on the left lower panel. You see the big opening. We repaired it with a piece of Duragen, and she left the hospital the next day. Here's a little bit of an intraoperative video here, so you can see how it was partially calcified. So the left is cranial, right is caudal. The spinal cord is right ahead of us, and we nibble that down, partially calcified disc fragment there. Again, I don't want to bore you too much with that. So we keep going, we free it up. You can see the defect right in there. This is very, I don't know what instrument they shoved in there, but you can still, the arachnid is there. But now the thecal sac is entirely decompressed. And you can see in a postoperative MRI, there's no more stenosis on the right lower hand. You see the postoperative MRI. Another great indication, and it's the last indication here that I want to talk about, is cervical decompressive surgery. So we call it the cervical endoscopic unilateral laminotomy for bilateral decompression, CE-ULBD. Here, the target area is the juxtaposed edges of the index level lamina. Again, that's what you have to hit, either with palpation, navigation, or robotic systems, right? Once you have that, the rest is easy and normal surgery. And then the principal anatomical landmarks for decompression surgery, we typically take the yellow ligament attachment. Here's a case here, 84-year-old guy. He's actually a very pleasant radiologist here from Seattle. And he came to me with highly myelopathic, unsteady gait, and severe stenosis at C2, C3. You can see the preoperative MRI. The spinal cord is in here. Obviously was, as you can see there, greatly, he had kyphosis, hyperlordosis in his neck to compensate, sick as a bone with lung cancer, other sort of like comorbidities, a front-back deformity correction, which, we do for younger patients, would have been a disaster for this guy. And so we did a decompression there, and his hand strength recovered to some degree, and his Babinski's myelopathy resolved. So I think a great indication. And again, I don't want to prolong this too long, but I think I would challenge anybody for these last two cases that there's really nothing on this world right now that would have been better for these two patients. Anybody. We can discuss it afterwards, but not to my knowledge. Now, obviously can do this case via tube too. It's not a big deal. But the precision you get to the endoscope just allows you to do these surgeries much safer and much more precise. Last little indication, we wrote a paper on that too. What if you've already done your traditional surgery, put in pedicle screws, everything is happy, you provided your patient with your final surgery, as we always sell. I have a lot of patients that come to me like, I saw this surgeon, he offered me a final surgery, and I was like, yeah, right. You know what the end of a degenerative spine disease is, right? Right? Everybody knows it, right? What's the end of the degenerative changes in your spine? A lot of patients ask me, is it going to stop afterwards, right? We all know it doesn't stop. It's life, right? Degeneration goes on. But what you can do there is you can find remedies. For example, she was a 39-year-old female. She had a T-lift cage that was retropulsed. You can see it go into the canal, had radiculopathy. So we went in there with a small endoscope, found the nerve root, found the cage, drilled it down, and she went home an hour afterwards, right? Traditionally, would have to take all the screws out, open everything up, put everything back together. Big mess. So sometimes you can really find very sensitive solutions. Takes me to the conclusions. As we have seen before, too, this type of surgery minimizes the invasiveness. And again, I use it in my hospital because 30% of my patients have transplants, extremely sick, and I'm extremely proud that of more 1,000 surgeries, we haven't had a single infection. Not a single infection of 1,000 patients, and a third is immunocompromised. It's a big deal. It's a big deal. Ask your hospital administrators for that. Ask them, it's a big deal. And then the other thing is, I think we can achieve, I don't want to claim that it's any better than anything else. Everybody's a great surgeon. I learn so much every time I go to these meetings and talk to other surgeons. There's tremendous talent everywhere. But I think we can achieve a very similar outcome with this procedure compared with traditional surgery. But I think that where it really shines is that we can decrease the invasiveness. And again, we need other technologies, it makes a big difference. Like Eric told us, that you don't have to dig around and you have to try often. You can be very precise and very targeted. But, this field is very young, and we are still, working on making the tools more efficient. And we need adjuncts like navigation, robotic systems, augmented reality, which are going to come the next couple of years and will sort of significantly enhance and ease the learning curve. With that, I want to thank you for listening. A lot of this stuff was developed together with the support from Troimax. They have an academic society now, Espinea. We also worked with the AO Spine to develop a step-for-step curricula. And then I went together with a couple of surgeons, and we put up a book describing all these, basically summarizing the experience of 7 years of teaching residents and fellows how to do this. So thank you for listening. Any questions? Eric.
Thank you, Chris, for this lecture. And I'm so happy to have surgeons like you in this endoscopic field, because surgeons like you push the endoscopy to a next higher level. So what I'm interested in is this dural tear. Can you describe the technique to repair a dural tear endoscopically?
Yeah.
Because this is a challenge.
Yeah, no, it is, and often there's a lot of. Now let's start off with let's we're in the Trump area, right? So I'm going to first aggressively go against everybody in the room, okay? Attack first, right? So how do you repair a CSF leak with an ALIF? When you have been doing an ALIF and you have a CSF leak, how do you repair it? I hope directly, right? You put a stitch in. Everybody puts a big stitch in to make sure everything is right, because you direct repair. Nobody repairs an ALIF directly, right? They put a piece of gel foam in there, put the graft in, close it up. Does anybody do it differently? All right, so that was the Trump way of answering that. But no, it is a big deal. See, dural tears are a big deal. In fact, I gave a talk at the ESMIS meeting just about complication. Take it very seriously. I do have 2 patients that have had a worse outcome because of a dural tear than I wish they would have had. The answer is right now that small dural tears, like the one that you saw, you can easily repair with an inlay graft. So you take a piece of DuraGen and you wedge it in there, and it wedges in that defect, and then you glue it in with TCL. If you can do that, and the defect is small enough that you can get an inlay graft in there, and you can seal it with TCL, it's a no issue. It's just a no issue. It's repaired, you're done. If you cannot do that, you can either convert to open, which I personally have never done, because even the 2 patients where I couldn't repair it with an inlay graft have done pretty well. Again, I have a whole talk on that, but I don't want to bore you with that. But I think that's very, like in my conclusion slide, a tool that we have to work on. I think a true CSF, a dural repair with staples or in other means, at some point we have to work on. And there's some ideas and some stuff to go, but 99% of all the dural tears we can repair in a sufficient fashion that patients don't have any sequelae. 99%. Big question.
It's a good talk. This can be through either yourself or Eric. But are you doing these with patients awake, asleep, and are you using your monitor?
Yeah, great question. So the question was, awake, asleep, where is the role of neuromonitoring? I've done occasional patients awake. I think it's a great way to do it awake because the patient gives you immediate feedback. The problem is you need an anesthesia team that is really on your side and that anesthesiologist who sticks with the patient. Typically, my team of anesthesiologists, they kind of switch through very quickly. There's trainees and stuff, and so I found it very difficult at my place, but I want to revisit it. So right now I do 99% of my cases asleep. For the transforaminal approaches, I use monitoring. And the monitoring is both passive, so you have spontaneous EMG activity, but also active, which has really made a tremendous difference. So think about it like in a very kind of like, like you have a really bad foramen, maybe like after a T-lift, you have to clean it out. So what we use is we use the bipolar, the VaporFlex, and hook it up onto the stimulation, machine. And then you can not only see the stuff, you can also stimulate and see where the nerve elements are. And we have submitted a paper on that, and it works really well. So the threshold is roughly below 10 milliamp of stimulation, you typically get a positive response. And so if you don't see the nerve, you can typically stimulate it and stay safe. And it's a really good trick, and it tells you where the exiting nerve root if you don't see it because of scar tissue. So we use it both for passively for safety and actively to find nerve roots. And then I think it's worth the money.
Christoph,
Yeah.
This is the first time I think I've seen your talk, so I'm just going to push back a little bit because I'm non-endoscopy. And I love the back and forth.
That's perfect. Yeah.
Instead of a bunch of yes men to Trump, you got to have voice of reason or someone else. One of the first figures that I see with your talk is a MIS or open complication rate of 32%. That isn't what we're seeing. I mean, when I consent my patients, I tell them like 4 to 10% risk of complication, but 32 seems a little high.
Yeah.
What do you think?
Yeah, no, I agree with you. I mean, I'm shocked by these numbers. I mean, the reason why I put them up there is because they are the best data we have. Those are prospectively collected data. Now, the interesting thing is the International Spine Study Group has done a study where they looked at retrospectively reported outcomes, so like what we remember, and compared it with prospectively recorded complications, and they were twice as high. So, my MIS group, endoscopic tube, so the MIS group, I compared my first 50 endoscopic lamis to, had a complication rate of 26%. And I would have never in the world told the patient that I have 26% complications. Never. I mean, like, come on. I did 3 of those. I did 3 of those my last day of residency. All right, 3 endoscopic. That's we were breathing this stuff. I think it's high. I think it includes like also stuff that we often don't see as a complication. Like, is one day of having an in and out cath really a complication or not? I think they're minor, but I think there's a couple of things to that, right? I mean, I think this field needs to be driven by surgeons who put those numbers up there. All right, and we all have to be very honest of what we do and what our outcomes are, right? I mean, I think for us to kind of, I don't quote my patients a 30% complication rate with an MIS decompression either, but it's like if you really put everything together, all tiny little things. I mean, I was at 26%. I think that's, and again, the residents put those data these days, as you know. I mean, like, I have no input in what the data is. They just find it in all the charts and OR reports, and that's what it is.
So let me ask you this now, as a surgeon now who wants to be interested in endoscopy,
yeah.
What is that bread and butter patient? What is that bread and butter, the MRI finding, the clinical exam? Put it all together for us non-endoscopy people, where you've traditionally been taught open, but this is really where endoscopy is going to succeed.
Yeah. So I think, like starting out with that, again, I do 99% of my non-instrumented spine with endoscopes. And I think, but I'll just give you like 2-3 procedures where I think it's unbeatable. Number one is the cervical foraminotomies. You can't beat it. It's faster, it's better, you have a defined endpoint, right? Cervical foraminotomy, if you do the microscope, you're done when you can shove in the 2 caries. And well, I don't know, it's never been good enough for me. But the endoscope, I see the lateral aspect of the pedicle. I look out and I see the nerve root. I feel that I'm done, check mark, done. Small, patient goes home an hour afterwards. Can't beat it. Thoracic discectomies. I loved taking down the pleura. It just was my favorite surgery. I mean, I loved it. It was just like you're right next to the aorta. You feel like a real surgeon. I mean, my God, please. Why did you take that away from me? I love this procedure. I love it, and I would do it all day long. If you guys send me only, I would do the surgery all day. Retropleural, like the invasive retractor, you go in there, you have everything in front of you. Oh man, I love it. Can't do it anymore. Why should I do it? I can do the same thing with endoscope, so can't beat this. And then one other thing I think is really good is lamis. I mean, it's just they're a little bit on the. They take too much time still. So at one level lami takes an hour, but they are so good. They are so good. If I would ever need a laminectomy or anybody in my family, I would fly across the world to have it done. It's just so precise, nothing is going to happen. It's not there yet, we're pushing the field, but I mainly push the field to keep it with us. I like to push this field so that, like spine surgeons are going to develop this and keep this safe, right? There's a lot, as you know, there's a lot of kind of shady business going on with these kind of things. And it's our obligation, I feel, to develop this and then either say, is this good enough or it's not good enough? And if it's not good enough, we move on. I mean, there's going to be something else better and greater afterwards, I'm sure. This is not the last thing in what we see. What's going to be next, like little miniature robotic systems that you can fly with a remote control. Cool. Any other questions?
Great talk, Christoph.
Cool.
Appreciate it.
Thank you.